I'm going to give you a little bit of an overview of the topic and then turn it over to Tor, who's going to talk about imaging, and then to Hank, who's going to be talking about the ethics side. Okay, so by looking at people, you can't necessarily tell who's going to respond negatively and who has good coping skills for pain. You just can't tell. So this really it's interesting that there's a huge variability in our not only how we feel pain, but our emotional response to it and our sensibility. The only way we truly know if somebody is in pain is through a self-report. So somebody has to tell you they're in pain, and we have to believe them because that's the only way we actually know. Nociception, which is something related but not equivalent, is an objective measure, and it reflects a system that creates the pain or has activity in response to a painful stimulus. Okay, so the nociception is what happens in your brain, in your spinal cord. It's the neural activity that ends up being related to pain, and a lot of the time, pain and nociception are pretty much equivalent, but sometimes it's not equivalent. More recently, we've looked at structural and functional connectivity. I won't go into the details, but we have found some key differences in how men and women are connected in areas of the brain that we think are related to this effect. So we have to think about these things. The other source of variability we have to think about, I think, which is going to be quite interesting for developing biomarkers, is how different we are in terms of how we balance different tasks and pain, and also how our mind may spontaneously wander away from pain when you deliver a stimulus. And what we have found, and I won't go into the details, but there are different kind of phenotypes of people. So in studies we did over the last few years, we found that there's these two kinds of phenotypes, A and P. P being people who were pain dominant. So if you give them a painful stimulus and you ask them to do a task, they get worse at doing the task when the pain is on board. The A types, the attention dominant types, actually did the task better as you delivered stimulus. So they tried harder to keep pain out of their mind and get the task done. And their brains reflected those differences. So what about this? If an individual feels pain, the pain matrix is activated. The pain matrix is activated, therefore the individual must be experiencing pain. So how many would agree with that, right? So this is the problem of reverse inference, and specifically in the pain system, because the pain doesn't reside in one particular place. So we need to keep that in mind when we're coming up with these sorts of protocols. Okay, so three kind of things that pain biomarkers might be able to address. Diagnostics is one in which I think it might be extremely problematic. The other two directions, prognostics and prediction and triage for treatment efficacy, I think hold greater promise.
First of all, pain is both overtreated and undertreated. For example, if you are a woman or an ethnic minority in the U.S., you have to report more pain to get the same level of treatment. So people are not really believed equally when they report that they're in pain. Pain is often not effectively treated, unfortunately. So it's not really just a question of understanding how much pain you're feeling, but what type of pain you're feeling, and more importantly, what's the underlying cause, and so what treatment might be best for you. So, of course, we need to ask people how they feel. Self-reports, unfortunately, have far more complex determinants, I think, than any single brain system itself. And so this is one of my favorite examples from psychology. They looked at, this is Norbert Schwartz and colleagues, they looked at the percentage of patients who reported somatic symptoms, these are clinical pain symptoms, more than twice a month. In this sample, 65% of people reported such symptoms. And this was the case when they were asked how often they experienced symptoms on a scale that ranges from twice a month or less to several times daily. But when they changed the scale anchors and gave a different scale to the same matched group, so now the scale is never to more than twice a month, the response rate dropped almost to half. So clearly that's a large effect, and it's purely an effect that's caused by the usage of the scale itself and how that's delivered. So the traditional logic has been one of overlap. This is a map from our lab of acute pain processing. It's really things that increase in brain activity as the level of noxious heat goes up on the skin. And this is a very typical view. I won't go through all the areas of the brain, but suffice it to say, it's a very sort of prototypical pain circuit that's activated. The question is this a biomarker for pain? So can I say, if I activate this circuit, then I'm probably experiencing pain? So the problem is that these brain maps, like the pain map I showed you, are not biomarkers. We have several problems we need to address. There's a problem of definition. Every study produces a little bit different pattern of brain activity. How close is close enough to count, right? We don't know. So we don't agree on precisely which patterns we should be testing across studies, which voxels, and how strongly they should be activated. So there's a lack of exact replication that's plagued this field in psychology, and people are addressing it now. The solutions, then, from my perspective here, are this process. Number one, we can identify patterns or neural markers that are optimized to be sensitive and specific to pain, and we'll do that using machine learning. Number two, then I can quantify their sensitivity and specificity of these patterns to different conditions, and also the generalizability. Does it apply the same pattern, apply across individuals, across studies, across scanners, across types of pain, etc. And then, three, I can use these defined and validated markers, annotated with data about their sensitivity and specificity, to assess pain, to understand mechanisms, to predict treatment responses. So this I see as really a promising way forward. fMRI patterns have now been used to decode a large number of things, which decode means make predictions about a psychological outcome or category, including things like visual percepts and what objects somebody is seeing or attending to, which semantic categories they're thinking of, contents of memory, and a number of other things. So our analysis framework works like this. We deliver noxious heat to the skin, and you can see a thermode there in black, and we can vary the intensity of that noxious input. We measure activity every second or so in a number of different brain regions. I've listed 4 brain regions that are important, but of course we're going to do this for every one of those 200,000 voxels in the brain. And together, we're going to look for a pattern of activity across these different regions and voxels that's predictive of how much pain people end up reporting. So we'll end up generating a predictive map. And one key point here is that we're going to generate this map under highly controlled conditions, normative conditions, where we know what the ground truth is. We know people can rate pain very reliably. We know that there are minimal cognitive biases, and we've constructed our experiment to do that. So once we have the map, then we can test it in more interesting cases, where we give people a placebo treatment, or have them engage in mindfulness practice, or get a drug treatment that may or may not work. And we can evaluate its effects then in less certain cases. If we can accomplish those things, we can confirm acute pain with multimodal assessment. We can understand potentially types of pain that are defined by different physiological systems, and hopefully we can personalize treatment. What we can't do, and we could discuss this more, is really disconfirm pain, because any given person might have real pain, but with a different neurophysiological basis.
I think with this issue, we've got a really interesting question about how the law might and should use new technologies for diagnosing, or not diagnosing, but determining whether someone in a legal action is feeling pain, and if so, how much. There should be some broader structure that insists on several things. First, good evidence of accuracy. The accuracy analyzed in terms of specificity, sensitivity, positive and negative predictive value. The accuracy proven on n's of more than 10 or 12 or 15 people. A standard problem in a lot of fMRI studies is the n's are very small. The accuracy shown on different types of people, men, women, old, young, different ethnic backgrounds, people who have had drug habits, people who haven't, people who are mentally ill, people who aren't. You're talking about probably n's of thousands here in order to do a good job, and it may turn out that there is no good diagnostic method. You won't know if there's a good one until you've done those kinds of studies. Those studies will be important. Second, I think it will be important to have studies of possible countermeasures. We also need to worry about whether or not there are standards applied for doing the tests. I thought Tor very usefully mentioned, got to make sure the machine's working. Well, that's good. You should also have standards of how long you put people in the machines, what you do with them there, et cetera, et cetera. That kind of standardization is not something that individual researchers on individual research grants are likely to do, but it's really important for getting something systemically into the legal system in a reliable way. Finally, I think you need standards that avoid the temptation to say this one test is the be-all and end-all, but say you add to self-report, to physician expert witness, to behavioral indications, this has one more piece. And if the science proves that it is a useful piece, then I think it should be used. How do we get from here to there? We probably don't do it with individual research grants to individual researchers. We need, in order to make this work, a large investment to do the studies, to set the standards, to come up with the protocols that needs to be done on a systematic basis. But what we really need is a systemic approach so that this diagnostic, if it can add value, is used in a way that is better, not worse, more ethical, not less. Thank you.